Day. And today we have an all morning Green Mountain Care Board. And I really did ask the Green Mountain Care Board to come in for a length of time. Really want to get a really detailed overview of what they do, what they don't do. I think there's a lot of misperceptions around a lot of the activities and the things that we have tasked them with. And so I anticipate that this is going to be pretty weighty. I hope it's a pretty weighty discussion this morning. And we're going to start with Chair Owen Foster.
Morning, and thank you, Chair Black, for having us in, and to the committee for giving us so much time this morning. It's really generous of you to block off this amount of time. There's a lot going on in healthcare, and we'll try and dive into that. We've organized the slides, and some of our teammates are here, our colleagues from the care board staff. We're going to give a pretty deep dive overview on the state of Vermont's healthcare, because I think it's really critical that everyone's very clear on what is going on in Vermont right now in healthcare. And then second, we have some more technical and granular perspectives on exactly what we do and how we do it, including on CON, hospital budget review, insurance rate review, and our data and analytics work. And so I'll start, and then we'll have some colleagues present some of the other detail. Okay. Is that working? Okay, so I'll start real quickly with a background of how we are set up and who we are. First, we're 5 board members and a staff of about 25, 27, depending on vacancies and whatnot. Established in 2011, the 5 board members all go through the same process to be hired. First, there's a nominating committee that is an independent organization. They take applications, they do interviews, and then they select names to pass to the governor. And then the governor selects from the names that are passed from the nominating committee. They're staggered 6-year terms. What that means is that ordinarily you would have different governors making appointments. Governor Scott obviously has been in office long enough now that he's appointed everyone on the board. And sadly, he'll be making one more appointment fairly soon, as Member Lunge is leaving state government in April, which will be big shoes to fill, as everyone knows. We are an independent agency. We're part of state government, but we do not work for the governor. We're independent of the governor. And we're quasi-judicial. What that means is many of our processes are handled almost like a court-like fashion, in which we receive evidence, we take testimony, we ask questions, and then we issue opinions and orders that the regulated entities must abide by. I'll give you a real quick brief overview on who we actually are as people. First, Tom Walsh is a health policy professor. He teaches at Dartmouth. He's also a physical therapist, and he's been on the board for about 3 years. David Merman is an emergency room doctor. He practices at CVMC and formerly practiced at UVM. And his wife is an ED doctor as well, also works at UVM. Member Lunge has been on the board, I think, about 8 years now, and she's a health policy expert. She's led a lot of Vermont's health policy work in the state for 20 years, maybe even longer. Member Holmes is the longest tenured board member. She's a professor, an economics professor at Middlebury, and she just started Middlebury's new health policy and health economics program. She's a very distinguished professor in that field and a wonderful board member. And I've been on the board since October of 2022. I'm originally from Middlebury, and I was previously a lawyer at a large law firm, and then at the Department of Justice here in Vermont, the U.S. Attorney's Office. I defended doctors in medical malpractice cases at FQHCs, and I prosecuted pharmaceutical companies and electronic medical record companies. I also did some drug and gun work here and there. The role of the GMCB, I think as the chair alluded to, is often sometimes confused. I get a lot of requests for why aren't we increasing Medicaid rates? And we have no authority over that. Why does Medicare pay so poorly? Again, we have no authority over that as well. What we do regulate, and we'll get into this, are insurers, and only part of insurers and only one type of plan. So what we actually regulate is the amount of charges, the rate increase, the premium increase that they can charge to their members. But that's only on the qualified health plans, which is about 60,000 lives. So if you think of health insurance, it's over 200,000 lives in Vermont. We only do one small segment of that. And as to that, we only do one small portion. DFR has other responsibilities as to insurers that we don't have. Hospital budget review, that's probably our biggest bulk of work. And what we do there is we receive hospital requests for really two things, essentially: how much more revenue they can charge and how much more they can charge commercial insurance. We call that the rate. So if a service costs $100 in year one, and then they wanted a 10% increase, they'd ask for a rate increase of 10%. And now the service costs 110 rather than 100. And then they'll adjust their revenue and say, hey, we had $1,000 in revenue, but we want 10% more revenue this year. It's 110. Revenue is really important to understand. And sometimes I think it gets a little bit confused. Revenue is pretty simple: price times volume. It's not just volume. It's not just patient care. It's also the price. And so that's something that we look at in our hospital budget process. ACOs, we review OneCare and their budget requests, their administrative costs, and where they're spending and how they're using their money. And then also certificates of need. And that's really just a request to build a new facility, to replace equipment, whatever it might be. What we don't do, though, is very important. We do not regulate FQHCs. We do not regulate independent providers. We do not regulate ambulatory surgical centers other than through the CON process. Mental health, long-term care, DAs, out-of-state providers, we have no regulatory authorities over those unless it's through a CON or it's part of a hospital. So if it's not part of a hospital, that's not in our bailiwick. And then on payers, we don't regulate Medicare and Medicaid. We do not regulate Medicare Advantage plans or self-insured plans. So like the teachers union has a self-insured plan. State of Vermont, we don't regulate those.
Leslie?
Well, I just noticed total cost of care, which you had was on the slide. And I'm just, if you could just explain that sort of from a high level.
Sure. We'll get into this a little bit more later, but the state has been in what's called the all-payer model for, I think it's 8 years now. And as part of the all-payer model, state has total cost of care benchmarks. That's part of the state agreement with the federal government. And we set the total cost of care benchmark for Medicare. We step in and say, here's how much, this is the benchmark that we're at.
For each hospital or statewide?
Statewide. The hospitals don't have a Medicare total cost of care benchmark.
How do you figure that out?
Well,
I mean, I know that there are a lot of people in the world in your world doing that, but I've always seen it and it's sort of a mystery.
So there's a couple components to it, but really what we're looking at is we're trying to come up with a way to get as much federal money as we possibly can and draw it in. So we want to set the benchmark rate at a level that gives us the maximal opportunity to draw down the federal funds through savings. So it's an annual decision that we make as to what the rate would be. And there's a range, and every year we pick the maximum. Yeah, every year we pick the maximum rate that we can to optimize our chance to draw down federal funds.
From the Fed, sovereign rate.
Correct.
So thank you for asking that question. And if I can elaborate, just
Please.
to clarify it in my mind. You set the total cost of care that Medicare, they agreed to that. And then if we don't spend that much money, or that Medicare does not spend that much money, they give us through the ACO.
Yeah, there's a couple steps. It's a target range of the rate of increase, right? That's the target that we're setting. And when we do a reconciliation with the federal government, there's a range that we can do, right? And so we pick the maximum range. And that means if we come under that range, there's what's called savings, right? Under that target. If we're under the target, there's savings. And the way the ACO model is set up, that savings, we can capture some of that savings. We get to keep some of the savings. So if you set that target lower, you have a harder chance of getting the savings because the savings would be, right? The gap would be smaller. So that's what we do.
What do we do with the savings?
We don't always have savings.
Okay. If we do have savings,
It goes through the ACO and then the ACO pays it out to the participants based on agreements they have with the participating hospitals.
and if we don't have savings, who pays?
Is there a kind of penalty or what
Is
is
there
it?
a penalty?
There can be, I don't remember exactly what's happened with that in the last couple of years. It's usually on Medicare, we do pretty well on the savings. It's on Medicaid and commercial where we haven't done well. And we'll talk about that a little bit. So there's three payers, Medicare, Medicaid, and commercial. Each one of those has a different target based on their negotiations with Medicaid, Medicare, or the commercial payers. Ideally, as a state, what we really want to do is maximize federal money because that's money we pay the least for, so to speak, right? Commercial, we pay really directly. Medicaid, we pay very directly. And in the all-payer model, we'll go through some of this. We've seen pretty good savings on Medicare, which means the Medicare spending is flattened, but we have not had that on Medicaid and commercial quite like we wanted. I think we should keep going because there's a lot
I have
here.
another question, and it may be you'll get to it, but I know, and it's not mentioned here, is one of your briefs is HRAP, and there's primary care involved in that, and that's of interest. So if you're gonna get to it, that's great.
Yeah, we can get into that in the data section. I mean, at a high level, the health resource allocation plan is a report. It's available. You can go online. You can see
I
various.
couldn't find it. I tried last night, and the one I found was like 2020, and maybe that's what we've got. So if anyone of you could help me find it, that would be great.
Yeah, we can send around a link.
That'd be great.
But HRAP is really essentially you look at what resources you have where and how much you have and where they're located, right? So you will look at how many primary care providers you have in this area, how many specialists, this variety, all throughout the state. So it's really an inventory of state resources statewide. But it's not really a plan for how you're going to spend those resources or how you're going to spend your healthcare dollars going forward.
So do you have any, well, we've been losing primary care practices, we know Bell's Falls and Waitsfield, whatever, and different payment models. But since that's part of your brief in HRAP, I was wondering about your involvement with it. And you may want to answer that later, but that's a question for me.
Yeah, our involvement with those practices and closures.
Probably not directly, I get it, but if you're looking at statewide resources, how do you allocate when you have a desert and that kind of
That's
stuff?
not something we do.
So that's what I'm interested in figuring out, since it is in the HRAP as primary care is one of your responsibilities.
Right. Our responsibility is in the principles of healthcare reform, which is here. And the way we implement it, though, is a bit of a problem, which I think is what you're getting at, is, well, what can you do?
Yeah, enhanced primary mental health care,
Right. So how do we do that?
Yeah.
We have regulatory authorities. We don't have funding authorities other than for hospitals and how much money they can have. So can we say, okay, that practice is going out of business in Lamoille or Waitsfield or wherever it is, or going, I don't know, changing. Can we allocate, we send dollars there? The answer is no, we can't. So this is a principle that guides our decision-making with our work. It's not actually an authority. So what we do is when we look at hospital budgets, these are the things, some of the things that we're considering and looking at. But an actual authority to send money to a place that we don't regulate is not something we can do. And that's part of, we'll talk about this a little bit later. Part of the problem, I think, in healthcare in Vermont is that you do have some silos of what's doing what. So we know that, Howard Center has financial problems, and certainly mental health is one of our, well, what do we do?
Well, there's my question. What can you do? Because number 4, you go down to 4, must be preserved and enhanced so that Vermonters have healthcare available to me. I love that, except that's not what's happening.
Right. There's a disconnect between the principle and then the authority to do something.
Mhm.
And that's part of the gap here that we can talk about. We have in the last several years tried to work more and more within the authorities we do have to address these as far as we can. And I'll get into some of those. But an easy example is the ACO regulation. So we have regulatory authority over the ACO, and we want to enhance primary care and mental health. So what do we do? Well, in the ACO context, we did 3 main things, and I have slides on those. But one is we said, you're not allocating sufficient money from your budget of your total cost of care, all the money you have, to primary care, and your administrative costs are too high. Cut your administrative costs and put that into primary care. We did that 2 years in a row. Another thing we did with our insurance rate review is we looked at how much money in rate increases hospitals were getting, and we saw a pretty big disconnect. Hospitals were getting very large rates of increase in payment from commercial. And that's critical because generally speaking, commercial is where places become solvent and have more money. And we saw the rest of the market getting very low, 0, 1, 2% rate increases. And so if you're trying to enhance primary care and mental health, you need to think about that. If you're trying to sustain the system around hospitals, you need to look at that disparity and question is that. And so one of the orders we did in our insurance rate review is we said you can't allocate. What was happening was the hospitals would have our rate that we would approve, and we viewed it as a cap, and the insurers could negotiate underneath that, however they wanted. The private parties could go negotiate under the caps. What was happening was they would take the cap as a guarantee. We get whatever the care board said. So we changed that and said you need to pay your rate increases based on affordability, access, and quality. The same thing we're all trying to do. There's sometimes gaps in disconnects in incentives between what the state is trying to do and then what's happening outside the states within the regulated entities. So that's one thing we did. And we did see actually a pretty good change where it became much more level. As we gave lower rate increases to hospitals, it did bolster up the ability for insurers to pay out money to the broader system, which, when you take money away from a hospital, or it's not taking away, it's giving less. And I think we gave a 4.1% system-wide rate increase, a little bit more than inflation in that particular year. So that is directly like, hey, we have less money, that's going to be hard for us. And it is. But it's also hard for hospitals when they don't have the surrounding supports that help them send patients to where they need to go. We don't want patients backing up in EDs. They back up in EDs if you don't have number 4, enhanced primary care and mental health. So that's something we've been trying to use the regular authorities we do have to address.
I'm a bit confused on what your responsibility is in terms of the insurance companies. Because I heard you go like this, but we only do a little tiny bit. And then I'm listening to you now, and it sounds like that's a little bit more than a little tiny bit. I
No,
need to know, and let's just take one, Blue Cross Blue Shield. What responsibility do you have with them?
we have responsibility for reviewing and approving and deciding the rate of increase they can charge their customers on the qualified health plan market. So they have self-insured plans and all kinds of other plans beyond that. We have no authorities over those. All we do is decide that one segment of their market, the QHPs. So they have a Medicare Advantage product. We do not review that. We do not get evidence on that. We do not make decisions on that. They have self-insured plans. We do not review those, nothing. So what we did as to trying to balance it was only in that market with which we have regulatory authority, that QHP market. So if you look at these large national providers of insurance products, Cigna, Aetna, United, we do not review them. We do not have authorities over them.
Not even Cigna.
No. If they don't have a QHP plan here, we do not review them.
Okay. Thank you very much.
No, yeah, it's a really good question. All right, so I'll go through this. I think it's really important that we are level set as a state as to what is going on in our healthcare system, because I do believe it is imperative it gets addressed very, very quickly. So first, Vermont healthcare spending has really been outpacing national significantly for about 20 plus years now. This is the per capita spending. That's how much we spend in healthcare dollars per person in the state of Vermont. And you can see Vermont used to be pretty close to national average in healthcare spending. And then we just started really outpacing the rest of the country significantly. There's sometimes, actually very often, a lag in healthcare data. This is only to 2020. I am quite confident that if you go 2020 to 2025, we will be, the gap will increase pretty significantly. Our healthcare spending has really been growing much, much faster than national in the last 5 years.
Is that because of price? I mean, you gave us that little equation, so just thinking about that.
Price is certainly a big component.
Mm-hmm.
I'm raising my.
Oh, I'm sorry, I didn't.
No, that's okay. How do we do in Medicare specific spending? Since, essentially Medicare is equal, even though I know it's not equal across the country, but how is our spending in Medicare per capita? How is that aligned with the US spending per capita?
Good question. I guess it depends on perspective. I would call it poor. And what I mean by that is we're not bringing in nothing of it. So from Medicare's perspective, they would say, you're doing a great job because our Medicare spending is quite low on an aggregate basis. So the total amount per capita we spend on Medicare is very low compared to national. We're right near we're in the bottom third for sure, and maybe even lower than that. One of the lower spending Medicare states in the country. Now, why is that? And any answer to why on any of these things has a multitude of factors. But I believe some of it is that we have difficulty getting in to see providers and we have difficulty getting access. So if you're not we have some of the lowest hospital admissions in the country. So if you have low admissions to expensive care, the spend is going to be low. Okay, well then flip it. Well, if that's the case, why is your commercial so high? And the answer to that is our prices are very high. Things are changing though fairly rapidly. This is a very fluid healthcare market. So utilization is spiking pretty significantly right now across really the entire state. So when I say we have low admissions, that's historical. And in the last year or two, that could be changing. It's also what are you spending it on? So if you're talking about Medicaid, it's a lot of younger folks or births or things like that. If you're talking about commercial, it's really that 20 to 65-year-old bracket that you're talking
Yeah. Woody,
Costs are going up, but is our healthcare getting any better?
Again, these are very nuanced questions. I'm answering kind of high level, so this is not a complete answer, but no, it's not. In the health outcomes data that you see, we're not seeing improved population health quite like we wanted, certainly not consistent with the trend in spending. So where we're really losing, so our physical health, if you look at the physical health data, it's been pretty flat. We haven't really seen broad improvement. It's been flat over 10 years, generally speaking. And then our mental health and substance abuse has been getting worse. We are worsening quite significantly on mental health and substance abuse. Overall, no, I don't think it's getting better. If you look at life expectancy, we're losing ground as compared to the gains that other states are making. So no, I don't think our health is getting better.
But we're also getting older, and therefore the costs are higher to treat older individuals. So how can we fix that, or do we start? I hate to say this, we're going to start regulating what we can and cannot provide as far as healthcare goes.
No, you don't want to do that. You want to regulate where the healthcare goes. You want it to be regulated in a way that sends those patients to the right place and not emergency rooms. You want to send those patients to places that are more affordable and available and accessible so they don't have long delays. And you want to regulate the price appropriately. And you want to regulate so you have a sustainable system, not one particular entity here or there. And in terms of aging, many other states are aging. They don't have our problems. I think aging is actually, frankly, a little bit of a cop-out at times in the state. We can do better, even if we're aging. We have a very healthy population, not just age. We're generally speaking a very healthy population compared to other states. And aging older folks are on Medicare predominantly, right? So a lot of those costs should be covered by the feds. That gets into another topic we'll dig into a little bit, which is Medicare cost coverage. How much of the care does Medicare cover? And that's one of the biggest problems I think we have in some of our systems is that we're not running on Medicare. What I mean by that is when we see a Medicare patient, some of our providers are losing significant money, 20, 30%, right? So if Medicare is supposed to cover 100% and it only covers 70% of your costs, you have a 30-cent gap on every dollar of spending. That's a problem as we age, because if you have more people in that bucket, you have more people that they're losing money on, and you need to find a way to make sure that Medicare is covering more. And Medicare is designed and intended to cover 100% of costs. Now, it doesn't always do that, and markets are different, right? So 100% at a hospital in Kansas or Boston might not be the same as our dynamics in our local markets here. But we're pretty far off as a state from running efficiently on Medicare. But we're going to have to, because you can't just keep making it up on commercial. And that's this slide here, which is one plan, the lowest cost silver plan in Vermont is this line, and this is the United States. And if you map on Maine or New Hampshire, which are equally old age states as Vermont, they're more around here. They're not here. And this is going up, as you can see, from 24 to 25 and 23 to 24, really, really sharply. And there's really no sign of that abating right now.
And is it because the requirements that we place on our insurance companies to provide certain care, is it partially the legislature's problem that we've created in trying to help, patients out there?
Yes and no. We do provide better benefits on many of our plans, and that is great for consumers. It also does cost more money for consumers, but the spike is not associated with additional or new benefits in our plans. The benefits in the plans have not changed in any way, shape, or form from 2020 and 2025 that counts for this, if they've even changed at all in those last 5 years. So sometimes I think if we say things, it's like, oh, well, that's why we have better, but it's not. Those haven't changed in these years. It didn't change from 24 to 25 or 23 to 24. It's really the sustainability crisis, I think, that is driving this. As places have financial trouble and they can't make it on Medicare, and Medicaid's certainly not enough. They only have one place to go if the expenses don't come down. So it's really, to me, we really need to be regulating and thinking about expenses. And that's what we've been focused on the last couple of years. When we award hospital rates, we look at their expense growth and is it reasonable? And in some instances, some hospitals are doing pretty well. Other instances, some hospitals, I think, actually have a pretty good reason why they can't, right? And we think about that. And then others, I think, have opportunities significantly better. And this just gives you a sense of the cost to Vermont families to buy insurance on the exchange. This is a chart of the premiums for a family of four on Blue Cross Blue Shield, and it's directionally pretty similar for MVP. The green is the platinum plan, and the orange is the silver plan. And you can see the increase. So this is just for the premiums before you even go to the doctor. In 2025, we're now approaching $50,000 for a family of four on platinum.
That's dumb.
It is,
Dumb.
yeah.
Sorry. A word, but.
Quote of the day.
That's so dumb.
It feels like it's just gonna get worse because I just happen to know that a lot of people are not even utilizing it because the deductibles are so astronomical too. So we're not even keeping people healthy while they're still healthy because they don't utilize their insurance. They have it because they have to, but.
Or they'll buy down to really plans with giant deductibles, and then they'll really try to not access healthcare.
Absolutely.
I do not see signs on the horizon that this will all of a sudden reverse or even flatten out. There's a caveat here, which is this is an individual plan, and there are subsidies for that. So I think it's 27,000 of our 30,000 Vermonters on QHP plans, on the individual plans, have subsidies currently from the feds. That drives down these costs very, very, very significantly. They are set to sunset at the end of this year, and we could see changes to that. And if those go away, we have a dramatic problem. What will happen for those families is devastating, and they won't be able to have insurance, period. That also has sustainability implications for the system, in that hospitals will no longer, and any providers, will no longer receive insurance payments for those patients. They'll get people who are paying out of pocket or who can't afford to pay, and they'll have bad debt and free care they have to give out, which further strains those entities' finances. And then you have a rise in medical debt for those families, and they will avoid getting care as they can't afford it out of pocket. In the subsidy issue, we don't know where that will land with the federal government. But the small group plans, there's no subsidies. So this increase is similar on the small group plans. If you look at all those other ones that I alluded to, we don't regulate, those are also directionally exactly the same. right? So it's not like this is something where we have subsidies and solves the problem. It's not the case. And then over here, you have the out of pocket. So all in, you're looking at $55,000 or so, regardless of what plan you're on. And I think this goes to your point, Representative Critchlow. This is from Kaiser. It's interesting, like the national news is starting to focus on Vermont for our healthcare challenges and problems quite a bit. The Washington Post, ABC, Kaiser, Financial Times, they've all been calling, like, asking what is going on in Vermont. When I first came on the board, a lot of the talk was about, oh, Vermont's so innovative. Everyone's trying to catch up to Vermont.
Mhm.
And then we started looking at, I started learning about our system from our team. And I didn't see that in the results. And so we've been trying really hard to raise awareness as to where things actually are. This is from Kaiser in the fall. They actually came here to Vermont to meet with people and speak with industry and everybody. And the headline is, in Vermont, where almost everyone has insurance, many can't find or afford care. At the bottom, this alludes to about, as Representative Pager question about, well, are we getting healthier with the spending? There's a line here that stuck out to me. It says, long waits for care have become increasingly common, according to state reports and interviews with residents and industry officials. So we're paying about as much as you can in the country, and we're having a difficult time even getting in while we're paying. This also alludes to Vermonters pay the highest prices nationwide for individual health coverage, and state reports show its providers and insurers are in financial trouble. So that's the problem we're in. Like, we usually solve these problems with money, and that's not available. So we spend the most and everything's going this way. So how do you solve that? You have no money to solve it. So we really need to think quite a bit differently at this time. And this alludes to the issue with wait times. This is from the 2022 study that the state of Vermont did. There's a report on how long it takes for people to get in to see specialists. There've been a lot of anecdotal information coming into officials about you can't get care. And we have to wait a really, really long time. And this was one of the results from that study. You can see some of the wait times are really, really long. The state average to see a specialist is 48 days. And some hospitals, Rutland, SVMC, UVM, were on the higher end, and some were on the lower end of wait times. So still 42 days at Copley, 41 at CVMC. That's long.
That is long.
It's very long. My wife is a diabetic. She tried to get an endocrinologist appointment recently. She was told July, and she called maybe November, December. That's really long to see an endocrinologist. I believe there's under 10 endocrinologists in the state.
I'm sorry, how many?
Under 10.
You're 10. What do you think? Yeah, and Leslie has a question about
In
this.
all fairness, it's not just Vermont that has long wait
Well, that
times.
was my
It's
question.
all over.
Is there a benchmark that we are compared to?
I'd have to go back and re-review this study to see what they use for benchmarks. Here, I think the best benchmark would probably be Dartmouth, which is in New Hampshire.
Mhm.
They had a 45-day average wait time. Again, this data, there's a lot of nuance in it. What are the specialties you're providing, right? So that can skew the numbers a little bit. So I think anytime you're looking at healthcare data, it's a collective, a bit of a mosaic to see the picture, because it's not like one number tells you the answer. And I think also you need to look for direction and temporal aspects. How is it over time?
Do we have a sense of specialists and the percentage of specialists within the practice within our state that are not affiliated with a hospital? I mean, I'm looking at these things and the word competition just keeps coming into my head.
I don't know the answer to that. Ms. Kill might, in terms of what's in the HRAP and the detail on that. We can try to answer that, but I don't know off the top of my head. If we segment out how many specialists are in hospitals or out of hospitals,
Okay.
certainly the bulk of them are in hospitals.
Okay.
But there are some that are not. This slide and the next slide really need to be flagged as huge, catastrophic, imperative, urgent issues. And this is the solvency of Blue Cross Blue Shield. Blue Cross Blue Shield is by far our predominant insurer in the state, and they're one of the best payers for our providers. whether it be hospitals or others. They pay a lot of money for services, and that keeps the system, the providers getting the money afloat. Blue Cross is facing severe financial challenges, and they cannot be overstated. If Blue Cross has a difficulty paying claims, and that's what we're talking about here, that means providers don't get paid. That means you might not be able to get care. That means those providers who have very low days cash on hand and negative margins won't survive. You cannot let Blue Cross go under.
Leslie?
So how does that compare to not letting Springfield Hospital go under? You've been rescuing along the way.
It's a question I don't want to have to answer.
Sorry. And you can pass. I mean, but it.
I won't pass.
Okay.
Losing Springfield Hospital would be catastrophic for that area. It's an economic engine. It certainly is. It's also, symbolically incredibly important. But if you were to lose Springfield, it would be devastating, but people can get care in other places that are nearby. It would be very suboptimal. If Blue Cross goes under, I think you see difficulty at many places. Springfield won't be here anyway. If Blue Cross goes under, Springfield goes under. Blue Cross goes under, a lot of
Other places go under. Yeah.
So-
So it's a broader, but I'm just thinking about the rescue idea. When is it good to rescue? When is it maybe not? good
It's
for the
not, it's
system?
not a good idea to rescue. You have to address the problem.
Yeah,
Go throw money at it and you'll burn money.
that's right. That's what I'm worried about.
So yeah, no, me too.
Yeah.
So if you want a bailout, the bailout will be gone in months.
Mhm.
So I'll give you a sense. So Blue Cross, I think there's a lot of numbers in my head, so I think I have them right. I think October Blue Cross lost $13 million. When they lose $13 million, what they're doing is they're looking at how much they brought in and what they forecast for claims and what claims actually were. So the claims were $13 million more in 1 month than they thought. I believe December they lost around $10 million. What that means is they have reserves, right? And the reserves pay when they're losing money. Well, when those reserves go down to zero, that's when you're in a real bind. And we'll talk about this a little bit, but there's right here. Okay. So here, this is the RBC, 337. That's a representation of how much money they have at the bank. You really want that, but if our target range, I think, is 590 to 745. So as of the date of this, which is August, it was 337. Okay, way below that range. I think that range is probably a little comfortable. We can be a little less comfortable in that range and be okay. But 337 right now would be a pipeline dream. They're nowhere near 337. And I believe some of the information is confidential, so I want to speak where I can. But to get to 337, I might give my left pinky. It's really a difficult spot. And the issue is the claims are way above what they thought. It's not just hospitals or Vermont providers, it's pharmaceuticals too, right? There's a lot of things that go into these claims, and we don't have control over pharmaceutical costs. We don't regulate that at all. We don't regulate pharmaceuticals at all. We are starting to evaluate how we can, and that was something the legislature allocated money to the care board to do, and we'll talk about that later. But until you do that, it's going to be several years before you can do it. As soon as you do it, you're going to be getting sued. A couple of states have set these up and they've been sued, and the pharmaceutical industry has a lot of skilled litigators. But
But we have you.
you're saying I can go be a litigator. So you throwing money at the problem won't solve it. It might buy you a month or two, but you really need to address what's going on with the claims where you can. And to my eye, what is happening is we have extremely high prices at some facilities. And then when utilization goes up at really high prices, what does that mean? Price times revenue equals volume equals what insurers pay and everyone else pays. So I think there's talk in this building, hey, a revenue cap is a care cap. Well, someone's got to pay the revenue. And you also have to look at, is the price appropriate for that revenue or for that service? And that's where we're getting in trouble. Really high prices as compared to nationally, and now we're on a huge upswing. And that's causing some of these serious financial erosion.
Did you have a?
Yes, I have a quick one. The joining with the state of Michigan, is that does that have an adverse effect on Blue Cross Blue Shield? I mean, are all of the claims dumped in one bucket?
No, they're treated as separate entities for financial purposes. There are some, I guess I'll call them back office synergies and technologies they're trying to utilize from Michigan in Vermont. Look, I haven't studied exactly all the nuances of their arrangements, and that's beyond my scope. But I would not think that it has an adverse impact on that at all. If anything, I would think that it's actually positive because Michigan is providing them significant loans for solvency purposes. They are taking out notes and loans from Michigan that they have to pay back with significant interest. So to represent Goldman's point, backstopping things doesn't work for too long. And Blue Cross's credit rating has been downgraded several times in the last couple of years, and now those loans cost more money. So you have to address the problem. That's where we're at. You can do that, and that might be something that you can do to buy time, but we need a plan. And to Blue Cross's credit, they've been outspoken about this recently. They've come out and said, this is where we're at. They sent a letter a couple weeks ago. I think it was a couple weeks ago. And in that letter, they said, Vermont's commercial cost of care greatly exceeds that of the rest of the nation. Blue Cross Blue Shield Vermont's spend is 33.5% higher than the average for Blue Cross Blue Shield plans in the Northeast and 42.7% higher than the national average. So Northeast, Maine, very old, Rhode Island, very old, Connecticut, old, New Hampshire, old. And in the Northeast, Blue Cross's spend is 33% higher than those other aged states and 42% higher than national. That's dramatic.
Mhm.
Why? Charges from Vermont hospitals and healthcare system account for most of the difference. So it's not the only reason for the system, for the difference, but it is part of it. And that's not to blame hospitals. We're not in a place where blaming is going to help anything, but it speaks to a couple things. Our structure of our healthcare system, which Act 167 is intended to address. And then what I mean by that also is hospitals can have high costs because they do not have the supports around them. And they'll tell you that. I think Dr. Leffler at UVM has been very outspoken about that. Patients are backing up in the ED. It's a very expensive place for patients to back up. So if they don't have long-term care to discharge patients, they don't have primary care or urgent care, it gets expensive real quick. Then there is the expense growth, which is very, very high, and we have to get a handle on. I'm going to interject with like a piece of good news, actually. Yesterday, we had DEVA come in and present to the board. We had with one of our hearings, and a year ago or a year and a half ago, the Healthcare Advocates Office started pitching this technique called silver loading. I'm not going to get into the details of it, but essentially what it does.
Oh, no.
Okay, all right.
It's like,
Essentially, what it did was allow people to pay for a silver plan to get the benefits of the gold plan without additional dollars. And last year, 5,500 Vermonters took advantage of that through some work that a number of people did. So 5,500 people in Vermont now have plans with better coverage than they had a year ago. And so that's really a highlight, I think, for our system. We should be pretty proud of that. The other thing I'll say is we haven't lost a hospital. And that's a very positive thing too. Nationwide, you're seeing hospital closures, especially in rural communities all over the country, hundreds. And we haven't lost one. That's really good. And we should be proud of that. It has come at a cost. It's cost us a lot of money and it won't work going forward. But to this point, these increases have helped us ensure that we have that care in our communities. Is it sustainable? Absolutely not. Do we need to make changes? 100%. But to this point, that is something that I think is a positive. A negative is that we have spent a lot of money to sustain it and it's not going to work. And this slide speaks to that. We look at days cash on hand as a primary metric of hospital solvency. You really want, I would say 120 to 150, 165-ish days cash on hand is kind of a safe number. 180 is really good. And from 2017 to 2025 budget, you can see that the system-wide days cash on hand is just going down. And this is as we've given really, really large rate increases to hospitals. Some at 10%, 10% the next year, 8%. I think UVM had a 14.77% in there. I think Rutland might have had a 15+% in there somewhere. And system-wide, we're just still going the wrong direction. So you can't pay your way out of this problem.
Sorry, Woody, did
Did you have your hand up?
Well, I'm just gonna argue with you, there a little bit. We haven't lost hospitals, but we've lost specialists. And in many cases, our hospitals can't treat those patients that come in for emergencies. And they also, as you know, they can't transport them to other hospitals like UVM or Dartmouth. And therefore, in many cases, they're just trying to stabilize those patients until they can transport them elsewhere. And in many cases, it's out of state. It's as far as away, from what I understand, Rhode Island in some cases, in upstate New York, what have you. So here's another question for you. When is a hospital not a hospital? When you lose your specialties?
I don't know of any Vermont hospital. Your point is well taken. I won't argue with you because I think you're correct. We have lost specialties. We have lost services, and you're going to lose more. It's not going to stop. There's going to be more that we're losing. That's a reality of where we are. So I think you're right, that 100% we have, and it's going to continue. There's no reality where there's money to not lose it unless we significantly raise taxes or are comfortable continuing to raise commercial insurance 15, 20%. There's not some silver bullet that we have that doesn't cost money to keep these services. It doesn't exist. So I think the point is well taken, and that's part of the problem is making sure we don't lose services that we must have. That's where we're at. Allocating our resources as best we can across the state and prioritizing what we need to prioritize. Will there be things that we want closer? Yes, 100%. But how are we going to pay for it? I'll give an anecdote. My brother lives in Middlebury and he was complaining that he couldn't get services at Porter. And I said, great. Do you want to pay 20% more next year? Can we? Do you want to and the answer is no. Okay, I'll go to Rutland. So yeah, we want everything in our backyard, but we don't want to pay for it. So that's the challenge. And I think right now, as we look at transformation, we have to look at what are we prioritizing? That's what you all do every day. And that's what we have to do as a healthcare system.
Leslie?
I think Representative Page's question is crucial as we try, what is a hospital in a way? Because, there's the rural emergency, models. There are other models out there. So as we look, when does it not become a hospital anymore? Or when does it? I think that's really a brilliant question, actually, for us to contemplate as we go forward.
It's such a brilliant question that I wrote down. What is a hospital?
I'd say, when is a hospital not a hospital?
What really is a hospital?
I don't have the technical definition.
Well,
There are different, you can talk about hospital sort of in layman's terms or in technical federal designation terms. And Representative Goldman's right. There's rural community hospitals, there's Soul community hospitals, all kinds of different hospitals, So technically, there's all kinds of definitions you can hit to qualify as, quote, a hospital. But no, if you lose orthopedics, that doesn't mean you're not a hospital. If you lose birthing, that doesn't mean you're not a hospital, right? So it's not really the mix of services. It's more than that. It's pretty technical definitions, location, services, size, all kinds of things go into it. I want to make sure.
Topper, did you?
Sorry.
I'm going to ask you a question. You may not have the answer. Hospital healthcare is the most expensive part of our healthcare system. From where you sit, do you feel there's an appetite now in Vermont to change the structure of how hospital healthcare is delivered and how it's paid for?
I think so, to a degree. I think there's nuance in how much. And to Representative Page's point, you're going to be losing services you want. And that's very, very difficult for anybody in any community, and any leader, and any board member, and any representative, and anyone to deal with. So I think we actually have to think about it more in terms of, is it going to happen anyway? And how do we not have that happen? And what do we lose when we focus so much on hospitals? But if you spend the money here at the hospital, are you losing the FQHC? Are you losing the mental health provider? Are you losing the long-term care? And so all these things are interrelated. If you want to keep orthopedics at a hospital, which we all do, but is that coming at a cost? Is it coming at a cost to our businesses in a giant rate increase? Is it coming at a cost to the long-term care provider? That's the challenge. I think we're moving in that direction. So this summer, the care board had an independent, we'll get into it, Oliver Wyman prepared a report, and there was all kinds of hoopla, news, and some vitriol even. And that was expected, right? We're talking about really painful decisions and painful realities. And I expected a lot of bumps, and that's part of the process. And the bumps are positive because you get the feedback, you get to challenge what's in there, you get to really think hard about it. So it's good that there was really great advocacy for local communities and local hospitals. And I think you get over that and then you start getting to work. And we're at the stage where we need to get to work. And I think there is appetite for that.
If I can just editorialize, and it goes back to the question of what is a hospital? And I think that, there's the backlash has been because the definition of what we consider our hospital, we're not imagining that it could be something else.
Right.
And that doesn't mean those services go away. It just maybe means
Provide them in a
we
different.
provide them in a different place and in a different way to meet the needs of the community. And that it's not the hospital. So I think it's a reimagining what we need our hospitals to be.
I think that's exactly right. And as we age, we need different things. We need memory care, we need long-term care, right? So if we're not losing orthopedics here, if we lose orthopedics here, does it give us an opportunity to fill a gap somewhere else? If we lose rheumatology there, does it mean we get to add primary care, which we so desperately need, right? These are trade-offs. And I think sometimes the dialogue is binary. I don't want to lose this. Well, it's not considering the broader things of what you can fill in instead, which is really good for the system, or the impact of having to pay to keep everything status quo. Just real briefly, I want to touch on that. The cost issue is really, you saw how dramatically difficult it is here in Vermont as compared to anywhere else in the country. That hurts some of the things we're trying to do in the state. It hurts our demographics. Young families can't, wealthy, old families, forget young families, they can't pay those rate increases. And when they do, they buy down insurance or they go uninsured or they move. It hurts recruitment and retention in the state. And that's bad for our demographics, which is a giant problem we all know we have. And then second, economic growth. What do you think a 20% rate increase does to a local business? Think about my family has a farm. Farmers can't afford it. Milk prices don't go up 20% every year. Think about food. Go to a restaurant. There are a lot of them on QHPs. Could they charge 20% more for their food every year? No. So you're really harming economic growth in our efforts on demographics. Our healthcare costs are going, no one wants to move to a state that's doing that. We need to stabilize it. And I will come back at the end of that with some ideas. There's no silver bullet. I think there's a long-term issue here, but there's some things we need to do immediately. I do want to get a little bit into, just briefly, I'll go through some of the financial difficulties at non-hospitals because we need to think about them as well. This is Little Rivers Healthcare. This is their days cash on hand. I showed you the hospitals are around 120. Little Rivers is down around 10 days cash on hand.
Where's that?
Little Rivers is down in Wells. And the community health centers, same thing. It's dropping precipitously. It's not this low, but it's been on this trajectory. Lamoille Health Partners is very, very severely strained and is going to need to make some changes to survive, right? So these are FQHCs. These are providers giving primary care, an incredibly important resource, and they're extremely financially fragile. So we talk about hospitals. Well, what about these guys that we really, really need? This is community health centers trajectory. And one of the big drivers of their decline, there's many, but the two big ones are one, in the cruelest of ironies, their healthcare costs. The cost for them to insure their employees. Roughly speaking, Representative, what do you like?
You scroll up a little bit, it was cutting.
Yeah, so community health centers, that's a big Burlington FQHC. They're down from 145 days cash on hand in March of 2020 to 62, and they're projected to lose over $2 million in fiscal year 25. When they lose $2 million, that will be a continual steep decline for their operations. Their healthcare costs to insure their employees has gone up. Give me a little bandwidth, but I think around 60% in 5 years. Howard Center in Burlington, their healthcare costs in the last 5 or 6 years are up over 100%.
Wow.
Their days cash on hand is single digits. So if their healthcare costs at Howard Center continue to go up, their financial solvency goes away. And again, talking about losing services, a hospital, what's a hospital, orthopedics, whatever it might be, well, these guys are going under too. And then you don't have the mental health care you need or the primary care. Two of the most important services, to represent Goldman's point, hey, you're supposed to be thinking about this. And that is one of the drivers of why some of the hospital rate increases we've been giving are smaller. If we give the hospitals a 10 or 20% rate increase, it makes it really hard for Little Rivers and Howard Center to afford their healthcare increases. And it makes it nearly impossible for them to get a sustainable rate increase. So we are thinking about it, but we're using the authorities we have, which are limited. That's where we're at. So healthcare costs, I also want to talk, where else they go? Sorry, go ahead.
Can I interrupt? I'm sorry. Do you have the authority to just set the rate for everybody?
I think the answer is technically yes. There are authorities in our statute that would allow us to do that. Practically, it's a whole nother reform, right? It's a whole nother effort to come up with a plan and policies and rules and rulemaking and regulation to do it. It would take 2 years. Yeah, it'd take an extensive period of time to set it up, and then you need the resources to do it, right? There are different tools, I think, to accomplish the same thing a little bit more roughly than prescriptively. But yes, technically in our statute, we do have rate setting authority, but then there's a whole set of things you have to do to get there. And that's what I want to talk about later is where are we as a state focusing our efforts? What are we doing? What's the right tool to use at this time? And you can't do them all. And we'll get to that, but there's talk about a division of planning in the state at the care board or elsewhere. There's talk about reference-based pricing, rate setting, ahead, global budgets. You can't do them all. I don't even know if you can do one, but we're going to have to pick one and do it as best we can. We can't do that. State of Vermont healthcare costs. This was presented, I believe, this week by the Department of Human Resources. So these healthcare costs, again, it's not just QHPs, it's hitting the state of Vermont employees. This is the rate of increase in premiums, 7%, 11%, 14, 15. What that means is either you raise taxes to cover it, or you take money from other things to cover it. And that's what we've been doing lately is we've been taking money from other things and starving other parts of the state to cover these expenses. Despite these expenses going up, they're losing money on the state employee plan. So 40% or so in the last 3 years, and last year it's $40 million in the red. And that's represented by this line, which is the amount of money they have in their what I'll call their surplus. That has gone down to negative $40 million. And this year, to cover that, there's a shift from money elsewhere in the state to cover these expenses. Right, so here, June 30th, 2024, net position of the fund to cover health insurance for employees is negative $40 million. Nolan.
Can I just add something to correct the null language of this clause? In EAA, you'll notice that EAA, they're asking for $18 million in BAA, and they'll probably ask for more money in the budget as well to help sort of shore that up. So they don't have to increase state employee premiums even more.
We did not do that. It's in a different area of the budget.
No,
correct?
it's different. It went to labor
It went-
or
okay.
I think it was asked if you guys wanted it. So it'll
Okay,
go to GovOps.
okay.
All right, property taxes, education, hot topic. There's another layer you've really got to think about, which is the healthcare costs that are driving them. There's a number of things that are driving education and property taxes, but one of the biggest drivers is also healthcare costs. These are the rate of, this is the rate of increase for the VHI, which is our teachers union, and the healthcare costs for those enrollees. You can see it went up from, it's been double digits other than in those COVID years. It was single digits, but it has continued to rise at a pace that we can afford. So when it goes up more than, inflation, they have to charge more to the schools, and schools have to raise property taxes, right? So what's driving property taxes? I think there is need for significant education system reform. I liken that education system reform to what we need to do in healthcare. We need to think about that kind of structural, large-scale change. So these are, sorry,
Go ahead, Leslie.
Who leads that?
who leads what?
That large scale transformation, blah, blah, blah.
Yep. So Act 167 was the statute in 2022 that charged the Care Board with working on preparing a set of recommendations for system-wide transformation. That's what everyone calls the Oliver Wyman report. That was delivered in September of this year. And then after that, Act 51 was passed that puts the Agency of Human Services in the lead role of health system transformation. We collaborate with them, but they're the lead on working on that. I believe Member Holmes and Director Krause will speak to that in detail.
We're gonna have a long discussion about 167. And then Jen will give us an overview of it today. It's a refresher.
So I'll just hit on these pretty quickly because I think I made the point, but the rising healthcare costs are impacting property taxes. In fiscal year 25, the average property tax bill is expected to increase about 18.5. And the increase in school spending can be primarily attributed to 16+ increase in healthcare benefits. So if you don't get healthcare spending under control, you don't get education spending under control, and you do not get property taxes under control.
They're saying that they're sicker? The teachers are sicker? Is that it's just being utilized? I don't understand why it drove it up so high.
Combination of things. One, there could be, I don't know, the teachers market specifically, are the teachers sicker versus the rest of the state? Generally, as a state, the acuity is what we call sicker. The acuity has been going up in parts of the state, the illness. Utilization, how much are they utilizing healthcare services? Where they're using healthcare services, and then the cost of those healthcare services. So if we at the Care Board approve a 10% system-wide hospital charge increase, that will make the price of all those services higher. And if you're using more and the acuity is worse, those combinations make it more expensive.
May I ask a question of Ledge Council real quickly? Because we're talking about if you don't get teachers rising healthcare costs under control, you have no effect. Can you sort of tell us briefly what authority the legislature has or doesn't have, or how the teachers' health insurance is set? And if we have anything to do with that, I guess.
Jennifer Carter from the Office of Legislative Counsel. Yes, but there's a lot of complications in the way that one is set up. Teachers are insured through an intermunicipal insurance association, which is overseen by the Department of Financial Regulation. And a number of years ago, in the last 10 years or so, some of that. So bottom line, yes, the state has authority and can take up more authority should you choose over teacher healthcare. The legislature set up the Commission on School Employees Health Benefits that regulates some of or determines some of what the benefits are and how the premium split is between the teachers and the districts. But some of that is also determined locally with every district and every school budget, reflecting some of the choices that are made there. Yes, the state can have authority. There's no federal preemption issue, if that's what you're asking.
Okay.
But it's not a standard sort of self-funded ERISA plan like we talk about the way the state employees are.
Okay,
But we can regulate those as well. There's a governmental exception.
okay. Topper?
Also, you have to, I think, you have to consider the collective bargaining process.
I mean, you should be aware that there is a collective bargaining
Yeah.
process, but the state can determine the extent to which that bargaining process takes place. So you could take it out of collective bargaining and set it at the state level. You have significant authority there as well.
So real quick, I did want to talk about some of the drivers of why our healthcare costs are going up within providers. And there are significant staff shortages at hospitals and everywhere throughout the health system. Recruiting nurses is very difficult. Primary care providers are down across the country. Drug costs, particularly the GLP-1s, are really expensive and utilization is going up.
Can you explain what a GLP-1
Oh,
is?
yeah. It's really a diabetes drug and used as a weight loss drug as well. They're Ozempic and Wegovy came on the market in the last about a couple of years. Extremely expensive and uptick in utilization of those products, which, they have a really great purpose and they do really great things, but they're really expensive as well. And then there are inflationary factors, such as even the cost of linens or laundry for hospitals, surgical equipment, all of those things are going up as well. So when we do our hospital budgets, we try and look at what's our expense growth at a particular hospital and how does that compare to regional, other Vermont hospitals or national peers. So easy example, what's Dartmouth's expense growth as compared to UVM? It's a pretty like hospital, or Albany or UMaine. We have comparison groups that we think about and look at and trying to decide, okay, is this acceptable? And then you look at, well, where's the money going? And that's part of our regulatory work. I went to the governor's budget address and I heard him speak about the 6% expected property tax increase. We're nowhere near a 6% healthcare cost increase. And he was lamenting, I think appropriately so, that that's a large increase for people to bear after all these large years. But to get the 6% in healthcare, we're a long way from getting the 6% increase in healthcare premiums, a long, long, long way. And again, that has all those collateral consequences across so many aspects of our state. Okay. So we're going to go a little more technical now as opposed to high level and get into some of what we actually do and how we do it. So first, I'll speak a little bit about hospital budget review. So we're tasked with establishing hospital budgets that meet the state's objectives described in the statute, the principles of healthcare reform. Review the budget submissions, they request money, essentially, and they explain why. And then we look at what we're trying to do as a state and try to make decisions that support and further the state's objectives. And those objectives tie back to the need to increase access, improve quality, promote efficient economic operation of hospitals, and balance healthcare needs with the ability to pay for care. If you pay more, you might get better access, but you might lose access in other areas, and you might harm your ability to afford healthcare. So these things are all really often in conflict. Each year, right around now, actually, the board goes through a process called guidance, and we put together guidance for hospitals as to where we expect them to be and how they should construe their budgets. So we tell them, really, we start communicating with them right around now as to where the board is going. And there's a stakeholder process where we engage with the healthcare advocate, with our staff, and then the staff with hospitals and the Association of Hospitals on what the guidance should look like. And then it's formed, it's published in March, and then hospitals submit budgets end of June, July 1. And they have a sense of, we'll put in guidance, hey, we expect revenue growth to be around inflation, 4%, or we expect your commercial costs to go up 3%. And that will be the guidance with which they build their budgets. And they submit their budgets, and then we review them, we have hearings, we take all kinds of evidence. I mean, the binders are huge and there's tons of data that we look at. And then we meet with them in a formalized quasi-judicial hearing, and we ask questions about their budgets and their requests, and then we make decisions. I will say our staff works incredibly hard. It's a 2.5-month process for 14 hospital budgets, I think around $3.5 billion. So very, very, very intense. We have a lot of young families, and it's in the middle of summer in July, August, when kids are home, and it's really tough to get through it for the hospitals and for the board, but it's necessary work. And I think it's the process we continue to work on and evolve and improve. as we go. So last year, we reviewed 15 hospital budgets. So the 14 that you would think of, and then Brattleboro Retreat. What's a hospital? Brattleboro Retreat is a hospital. They don't do a lot of services that UVM does or Newport does or any other hospital. Fiscal year 25, we approved a system-wide net patient revenue. What is that? So net patient revenue is the amount of revenue you get from providing patient care. There's other types of revenue. Some hospitals will have a pharmacy right in the hospital. That's not net patient revenue. That's, they'll go to what we call total revenue. It's a different bucket of money. Or some of these hospitals have a lot of money. I think UVM has about $1.3 billion. It's a big hospital, so they need a lot of money for, days cash on hand and to fund their operations. But they'll have revenue from that money. They'll have investment money. They have a hospital venture arm. They have all kinds of investments that also make money. That investment gain is not net patient revenue. So in fiscal year 25, we approved $3.7 billion in revenue, patient revenue, and then 4.1% increase over fiscal year 24. So system-wide, we approved the revenue at hospitals going up 4%. We adjusted.
But the NPR includes revenue from other income streams, I guess you would call them, investments, pharmaceuticals.
Yes, that would be in a different, not NPR. That would be in total revenue.
Okay.
That would be part of the NPR. So, right. So they would make, they could be up significantly in other areas.
So you do not control their total revenue.
We do review it and consider it in looking at their financial stability and how much money they may or may not need. But our budget decisions focus on this net patient revenue amount and the charge increase.
Okay.
We did adjust 9 hospital budget requests last year to limit the rate increases that impact commercially insured patients. So again, that's how much more can you charge for a service? It's $100 in year 1 and they want a 10% rate increase, it's $110. And this is just a made up example. Not much costs $100. But we would give something more like 3.1%. So now it costs 103. And the reason for that again is there's many, but one of the things we look at is how high are your prices already? If you have sky high prices and you're asking for 10%, you're going to have a hard time getting it out of the board. We're going to have a real difficult time saying yes to that. Sometimes there might be reasons to, but it's harder when you're really expensive to start with. And then the other reason is, well, what about mental health and primary care and the rest of the system? If we go to 110, that's $7 more just on commercial rate increase that's not available for somewhere else. It's not an endless pot of money. So that's the consideration we have. And then the people paying it, can they afford to pay 110? Because when they charge 110, the insurer has to go to the people and say, now you got to pay 10% more. So those are big drivers in our thinking.
Leslie? So I understand, and maybe it's evolving that in Maryland, state like Maryland, they actually put it in statute what the increases can be.
Mhm.
How does that work? Is that good? Not good? Or something to think about?
I mean, it's good in that it's very clear and everyone kind of knows what it's going to be. It's bad in that it doesn't give you much flexibility for different areas. I think there are different areas where you may need to go higher because of rurality or the population that is in that area. So I think having some flexibility with good guidelines is probably optimal.
Mm-hmm.
We have put it in statute in certain ways. And that was, I think, the second slide in the principles. And the principle said the amount of healthcare spending should be consistent with our ability to pay for it. And we recognize that expensive healthcare costs hurt access and patient health. So we haven't put it like a hard number, but we have put some guidance around, hey, we need to be able to pay for this. And that the overall healthcare costs should be contained. The other thing we did in the all-payer model is we set target ranges for total cost of care growth. And that was 3.5 to 4.3%. So when we put out our guidance, these are some of the things we look at. If Vermont had low healthcare costs on insurers, I could see a universe where we say, okay, and we have sustainability problems at hospitals. You could say, all right, we want to go higher on rate increases. We can afford to pay more. And the hospitals that we regulate need it. They're in financial constraints and they're really low priced. Let's go higher. That would be good. Unfortunately, we're in the opposite problem where they're in financial difficulty. Many have very high prices, and insurance, as we talked about, is extremely expensive here.
Do you think that hospitals, if I may, respond to your guidance through your principles? Do they have impact?
Trying to improve on them.
Mhm.
There is a disconnect sometimes between what the state's goals might be and an individual community or an individual hospital's goals might be. If I run a hospital, I want my hospital being incredibly robust services and financially solvent. That's my goal. And I want it to be sustainable, and that takes money. But that might conflict with the ability of others in the community to provide care and get appropriate rate increases and the affordability of the businesses and to pay the insurance, right? So we are trying to work with hospitals and others on thinking about how their mission aligns with the state mission. And I think that gets also to executive compensation. What are we compensating for? Because we have really high prices and really high expense growth. We need to be compensating and rewarding for financial prudence and awareness of the cost impact on the community. And I don't know that, I think there's sometimes a misalignment there.
Woody.
And since you brought it up,
That was a mistake.
the bonuses that has recently been in the press regarding UVM.
Mhm.
I mean, people see that and it's not a good image for UVM or our state healthcare.
As an individual state resident, I have feelings. As a regulator, I need to look at it pursuant to how we evaluate these things. We do have authority to look at executive compensation. We have in other contexts, and I'll talk about a little bit at the end, with the OneCare executive bonuses, which we did not permit. And it went to the Supreme Court. They challenged it. And I think correctly, the Supreme Court saw it the way we did, that we did have authority to limit executive compensation. On the UVM bonuses, I understand that seeing those kinds of bonuses is painful for people when they can't afford healthcare. It's really painful. I think to me, it's a question of what are you paying for? Are you paying for really good access? Are you paying for really good cost containment? Or are you paying for revenue growth and expansion and operating margin, right? Because those things can be in conflict with what we need as a state. We need solvent hospitals for sure, but is it coming on high prices or is it coming on lower expenses? And is it coming on providing the services that we need, like mental health or primary care, or else, right? So we need to make sure those things are aligned. And I know hospitals, boards and leadership will explain that there's benchmarking and we need to pay for talent. But talented at what? And that's what we need to make sure is that we're retaining the talent that does what we want to have happen as a state, which is help us with a system-wide sustainability and affordability problem. I think there is opportunity to consider and make sure those things are aligned correctly. Why regulate hospital budgets? I was just looking around last night and stuff, and I saw this from the VHI, the teachers union, on healthcare costs, and they said they'd gone from 16% rate increase down to 12%. And they noted in their fiscal year 26 communication to their members, for example, on the positive side this year, VHI's rate setting process, how much more they charge, benefited from lower hospital budget orders by the Green Mountain Care Board. Our budget orders allowed them, is one of the things that allowed them to have lower cost increases for teachers, which goes to property taxes and education spending. So why regulate hospitals? This is part of it, is to make sure that the system is as solvent as it possibly can be and appropriately, but also being mindful of what it's doing elsewhere. And I didn't know they'd done this till late last night, and I appreciate that they recognize that our effort, and frankly, the hospital's efforts to drive down their expenses that allow them to have lower budgets, benefited our teachers and health insurance costs. So if there's no more room to increase healthcare costs, and we do not have room in Vermont to increase healthcare costs, what do we do? And part of it is an allocation decision. Where and how are we spending our dollars? And is that the optimal allocation? Do we want to put all of our money into orthopedics? Should that be the biggest pot of our money? Should we put it all in mental health? Should we put it all in primary care? What's the mix that's most optimal for our population? And how do we get every efficiency out of how we spend the dollars? And, do we want more hospital leadership and administration to come up with ideas of how to run hospitals? Do we want more directly in patient care? Do we want more in nurses? Like, how are we allocating our dollars as a system and then within those various providers? And I just got this slide yesterday, so I can't speak too in depth to it. We're putting this together this week. I wasn't able to do all the prep that I wanted. So we can speak to this more maybe tomorrow or in the near future. But it's a look and a lens at how we're allocating some of our healthcare dollars. So all payer, Medicaid, Medicare, TRICARE, commercial is here, all payer. And then that's private payer. Private payer is where everyone makes the money. And here is how we allocated those dollars in 2005. Physician, prescription drugs, hospital. And then here's how we allocated private payer, the most important payer, I'll say. Physician, clinical, prescription drugs, actually gone down how much we're spending on prescription drugs, which I found odd. But again, I haven't had a chance to dig deeply into this slide yet. But I think we need to explore this more as we continue these healthcare discussions, how we're allocating the pie. Because as one goes up, something else is going down, or costs are going up. So the last 2 years, as the pendulum has swung on affordability in a pretty dramatic way, the board has given lower guidance. Actually, I think the guidance might be generally consistent, but the amount of approvals for hospital budgets has been tethered more closely to guidance. And that is for a couple things. One, it gives much more predictability. When we say guidance is X, if we follow through and do what guidance is, or really, it gives more predictability to the system that guidance means guidance. And that's beneficial to the system in planning how they're going to run their operations. It also is important just in light of the other problems we have of spending as a state. We can't go up 10% every year. So this is what the guidance was for the fiscal year is $3.6 billion. I believe that was like a 3.5 or 4% increase in guidance over the total spending over the prior year. Around inflationary, consistent with the state goals and the all-payer model goals. And this is just how much money each of our 15 hospitals had for their guidance number. So you can see there's some pretty small hospitals. Copley is 100, Gifford's only 66, Grace is only a $28 million hospital. And then Southwest a little bigger, medium size. CVMC and Rutland are pretty large hospitals for us. And UVM is extremely large. The UVM network, I believe, is around 63% of our hospital spend in the state. So a big network.
Can I interject? Do you approve the UVM Health Network budget, or do you approve each individual hospital within the health network?
Yeah, great question. I think sometimes as a state, we're a little sloppy when we say UVM. UVM, well, it's where I went to college. It's also a health network. It's also a UVM medical center. And there's the network, which runs 6 hospitals and a number of other things, right? So the network, and that's what's on Shelburne Road up in Burlington. Then there's UVM Medical Center. That's a distinct entity. And then there's CVMC and Porter Hospital. So UVM Health Network, within that network, has 3 hospitals in Vermont. And then it has 3 in New York, one in Plattsburgh called Champlain Valley Physicians Hospital, Alice Hyde, and Elizabethtown. What we regulate are hospitals in Vermont. So we regulate and make decisions as to those 3 UVM hospitals that are within the network, CVMC, Porter, and the UVM Medical Center up in Burlington. We do not make decisions as to the 3 hospitals over in New York.
I'm just thinking about some recent decisions that the health network has made. And maybe this is a question more for them. Would those decisions at each individual hospital that they chose to make those decisions at, were those driven by your guidance at that individual facility. I'm going to call it, for simplicity's sake, I'm going to call each of them a facility.
Mhm.
Or were those decisions made to cut from the network?
Yeah, really good question. And I want to caveat that I'm not an expert in all things and how the network runs its business. I do know from testimony we've received in prior years that the network has what they'll call a network-wide margin. They'll have a margin for the whole network, which is all 6 hospitals. And for credit rating purposes, they'll want that margin to be at a certain level. I think it's 2 to 3-ish%. And if they go low, they might have impacts. So if the hospital in New York is doing very poorly and it's a drag on network margin, they'll need to make it somewhere else, right? And what we don't want is the Vermont hospitals to be paying more to ensure network. We want everyone to be paying their own, especially as we have affordability challenges here. We don't want Vermonters to pay a lot more because of poor performance at a different hospital that we don't regulate or look at. So in terms of the decisions that were made, I think you'd have to ask them about that.
Yeah, I'm just thinking about, the closing of the 8 inpatient psychiatric beds at Central Vermont Medical Center, wondering whether or not that decision was made based upon your guidance around Central Vermont Medical Center, or possibly your guidance around UVM Medical Center. I'm just trying to think of how these decisions, because if you have authority over the individual hospitals, but not necessarily the entire health network.
Correct. As to the individual hospitals, we do, not the entire health network. Let me give one other background. So the network, and how is the network funded? The network, and this is directionally, there's probably some nuance in there that I don't appreciate, but the network is largely funded by the hospitals paying the network's expenses. So the network, I think I know the number, but I don't want to get it wrong, is, they have many employees. They have all kinds of services and resources that they use up there at the network, and those are funded by charging the hospitals to pay for them. So we don't regulate the network, so to speak, or at least it hasn't been part of our practice lately, other than through the hospital budgets. So a little bit indirectly. I think we will be taking closer looks at that as we continue, because the network has grown and is very impactful. And then in terms of the decisions, we didn't have guidance. We recommend closing an inpatient site. To the contrary, supporting mental health, Leslie, Goldman, sorry. There was an overage from UVM in 2017, and what the board did was say, okay, you're over by $21 million, but we have a mental health crisis in this state. You can keep that $21 million, but it's dedicated to mental health. And then there was a plan to support mental health at CVMC. So the board has taken a number of steps within the authorities we have to do those things. And the mental health example at CVMC was one of them. In terms of the closure, there wasn't guidance from the board that said, hey, we think you should do this. My view, if you read the budget orders and the enforcement orders, we highlighted a number of places where there's opportunity to comply with the board's approvals without going there to different services. And what I mean by that is we highlighted some operational opportunities, some expense growth opportunities, some of the debt that the New York hospitals owed to the Vermont hospitals. We highlighted those as part of our decision to say, here's where we think we can live within our budget orders. And they then make their decisions as they see fit with their organization. And they felt that that was the appropriate place to take action.
I wasn't implying that you made the decision to do that. I was more thinking along the lines, did they make that decision as at an individual hospital level, or did they make that decision at a health network level? So that's really more of a question for them.
Yeah, I don't know the answer to that.
Thank you. If I may. Oh, yes.
Just to make sure I understand, just for clarification, you mentioned the $11 million that UVM was going to invest in the site. Maybe
21.
Sorry, yeah, okay, not the one, right. Did that happen? Sorry.
Sordid history there.
Okay, I just wanted to be clear that it did not happen, from my understanding, it did not happen, and that is a piece of this conversation.
It has now partially happened. So there was a number of years where I wasn't involved in this at the time, but there was a number of years where they were trying to build a larger hospital with a much larger scale of mental health. The price tag on that got extremely high, and it was ultimately deemed not financially feasible, and it wasn't pursued. So that 21 million that the board had dedicated to mental health remained hanging out there for 4 or 5 years. When I got on the board, I think we took it up in spring of 2023 and said that, hey, what's going on with that $21 million? There was actually an advocate who came to meet with me. I can picture him, I'm forgetting his name, recently passed away. Tall gentleman who played basketball. I can't remember his name right now.
Oh, Liebertov?
Yeah, Ken Liebertov.
Yeah.
He asked for a meeting with me and he highlighted this and then we dug in and had a hearing. So as of 2023, it had not been used. And then we said, you've got to use this. And they came up with a plan and they have now used some of the money. So some of the money was used to do the urgent care mental health facility in Burlington with the community health centers. That's partially how that was funded. So while we don't have direct authorities we do what we can where we can. And that's a big, big goal of what we're trying to do.
Okay, so my second question for clarification, is there Vermont taxpayer money going to fund New York through the network?
That's my question too. If they're losing money, are we taking?
Are we
the bill?
funding them? Yeah, with our tax dollars. Or
I think, so money is fungible. And are you funding them with Medicaid money, Medicare money, or commercial money, or investment gains, or, you'd have to do an audit to really understand where it's going. I can speak to a high level, which is I do know that in their audited financials, this was something discussed in the budget order and with the network when we met with them, that the New York hospitals had significant debts to the University of Vermont Medical Center. I believe at the time it was around $60 million was owed from CVPH to the University of Vermont Medical Center. We asked for information more recently on that issue, and I believe it's currently around $93 million is owed. And we asked what those monies were being spent on. And there's so many numbers, so I apologize, I'm a little bit off. I believe at the $60 million, it might have been 30 million was for pharmaceuticals, to buy pharmaceuticals that were for New York hospitals. Maybe it was $20 million for physician salaries, and then maybe $10 million for shared services, which could be back office services provided from the network. What is allocated in the additional 60 to, I think, currently 93. 93 is all 3 hospitals. So we've asked for information and they indicated that it didn't come out of their budget, and they indicated it didn't come out of like rate increases. And I think they said it was a balance sheet item. What I understand that to mean, and you'll have to ask them, but I understand that to mean it's out of their cash and their reserves. It's out of their savings account, if you will. Their position is that it is one network and money can flow around as it needs to. But that is $93 million that is, as of that moment, owed to the medical center.
If I can ask it in a really simple way, just so I can understand it. We have 3 New York hospitals. Do those 3 New York hospitals generate enough revenue to cover all the expenses of those 3 New York hospitals?
We did ask for information on that, and I think it depends on what year and which hospital. I'm thinking of CVPH, which is the larger one in Plattsburgh. That's about a $500 million a year hospital, I think. It's about the size of CVMC, pretty big hospital. That one had deeply negative margins in a couple of the recent years. I think -7%, -8% margins. So I think the answer to your question on that hospital for those years, the answer would be no. And they also had negative days cash on hand, right? So we want 120, 150 days cash on hand at a hospital. I believe CVPH had -6 days cash on hand one recent year, -2 days cash on hand another. I believe Alice Hyde might have been around 80-ish 1 year, and in the last 5 years has dropped around 30, 40-ish roughly. And then Elizabethtown is quite solvent and stable.
So if there is excess revenue above expenses at a Vermont hospital and it's invested somehow to keep, cash on hand, you want them to have, capital for cash on hand. And that's earning interest, I'm assuming.
Yes.
And they're using the interest earned on that for New York hospitals. Theoretically, that's interest income that could be used for Vermont hospitals because the principal on it was generated from Vermont hospitals.
Yes, I mean, I think if there's,
Could keep their rates lower and could keep their Vermont hospitals might keep them from cutting 8 psychiatric beds at Central Vermont Medical Center.
there would be a number of options available if there was more money used and allocated here. So I'll just use the 90, I think it's 93 million. It's the last data I think I saw. That made it 92. You could use that 92 million to invest in an account to grow, right? They do quite well in their investments, so you would have more money. You could invest it in your plant. They have a relatively aging plant, so you could invest in some of your facilities. You could use it to invest in the outpatient surgery center and take less of a loan or put out a bond or whatever it might be. So yeah, I mean, there'd be a number of opportunities. It would give you more money to withstand losses. So I understand like the inpatient psych, it's not a big revenue source, but it loses margin. And so if you're losing margin, if you have an extra $100 million or so, that can help you withstand those losses. Yeah, there'd be a number of options. I think that's fair.
Could also be used to lower your prices.
Yes, although if it's it can, but I don't know if it's as great as you might think because they have to cover, like it's a one-time money as opposed to a rate increase, right? Think of it as one-time versus sustainable. So if you take 93 million and lower your prices for 1 year, that'll help you lower your prices for that year, which might be very beneficial. But the next year, you're not going to have that 93 to pay to buy down. But yes.
Do you think that it would have any influence, even a minuscule amount in the budget proposals that they put forward to the Green Mountain Care Board? The rate increases that they asked for?
I'll answer that yes, without being able to quantify it. So when we make decisions, we do look at how much money a facility has, like the total amount of money. So if you have $93 million less or 200, whatever the amount is, that can impact our decision on how much we grant an approval, right? So I'll give you a good example. Copley Hospital had very low days cash on hand. It was like 37 days cash, on hand. And they came in mid-year and said, we're in a real financial bind. We need more now. And we granted it. We gave them, I think, 7 or 8% increase in the commercial price. One of the main drivers was their financial position and solvency. They were so low in days cash on hand and not on a good trajectory. We didn't want to lose that resource. It's actually, by Vermont standards, a relatively well-priced hospital, and maybe even nationally well-priced. So we didn't want to lose a low-priced hospital that provides good services. So we granted it to them. And part of it was because their cash was low. Now, if they have 300 days cash on hand or 200 days cash on hand, which that would change the decision, or wouldn't change it. Could be very impactful. One caveat, and there's some documents that are public on our website. It's hard to capture all of the things in a conversation that's fluid, but it's a snapshot in time. So that money it's as of the date of the audited financials or when they submitted their information to us. So that can go up or down. Like tomorrow, they could move money and that number could be smaller. But where is the money moving from? Is it moving from the network? And was it medical center money in the first place? Or is it moving directly from New York? And that's what you want to look for, is where it's at. And directionally, where is it going? Is it going up? It used to be, I think it was 29 million in 2022, and now it's over 70 for CVPH. So you definitely want to make sure our dollars are working here because we don't have enough of them.
Thank you. Oh, Woody.
Just a quick question. Are there a lot of Vermonters that utilize those New York hospitals?
I would say not a lot. There are certainly some, and there's a fair amount of New York patients that come from New York to Vermont, including at the UVM Medical Center. I believe it's been a relatively static 14 or 15% number from New York to Vermont over a period of time. Some Vermonters get sure, but not a lot.
They get more than we get, basically. They gain more than we perhaps get out of the agreement.
I think you'd really need to do a deep dive in an audit to really say with comfort. But it is something that has been a concern, and then we put in our budget orders recently. That's something we're definitely concerned about. And that is relevant to our hospital budget enforcement process. So what happens if a hospital exceeds that cap, that budget order? We have a process and rules and regulations and guidance in place where we have a process that we go through and evaluate. Why are they over? What drove it? So if there's a bunch of revenue from sources that wasn't in the budget that came to be, in our view, that means you asked for too much commercial because you had other revenue. If you budget your expenses too high, we can give you more rate because we think your expenses are too high. And so we look at what the drivers are and the reasons for it. And then there's some other factors like the solvency of the hospital that had the problem, right? Had the overage. And so UVM on that one, we enforced full. I think they were over around $80 million for fiscal year 23. And we looked at the reasons and the board made a decision and we said that they needed to lower their commercial prices by an equivalent amount of money. So we didn't take the money away. We lowered the commercial prices in proportion to the overage. So the commercial prices decreased by a rate equivalent to $80 million, which was the overage. 3 other hospitals were over in fiscal year 23, Rutland, Northeastern, and Porter. And on Porter and Northeastern, the board took no action, allowed them to retain 100% of the overage because some of the drivers that we looked at didn't indicate that we should, in our opinion. And then on Rutland, we enforced half of the overage. And then with both UVM and Rutland, we spread it out over 2 years to make it less disruptive. Because when you take out a large amount, you have to deal with it. So we felt that the more appropriate path was to enforce over 2 years and only half for Rutland and full for UVM. But in discussing that, and the opinion is public and you can read it. But one of the things we did look at was the financial solvency of the organizations. And one of the things we did look at was the total revenue and debts owed and things of that nature. And also, again, the drivers.
So in 2023, they were over. You did not increase their rates. I mean, you didn't claw it back from them. You just didn't increase their rates to sort of offset that.
Correct.
But I believe you showed us a slide way at the beginning of the presentation that when you were talking about Blue Cross Blue Shield, the utilization has now spiked.
Yes. Right. So let me take that in parts. First, for fiscal year 23, the medical center had $80 million in net patient revenue above the board's order. And it's hospital's obligation under 9456D1 that they must comply with the budget order. And so a couple of things can happen. Either you can comply with the budget order, or if you're running what we call running hot, which means like over budget, if you see that as you're getting your monthly reports, you can come into the board under 9456F and come to the board and say, hey, we're going over budget here and we need to comply with your order. We're going to make an adjustment and lower our prices so that we don't go too high, price times volume. Or you can say, look, we're going to try and send a bunch of care to our primary care clinics so it's not an EED or whatever it might be. I mean, the easiest one is to reduce the price. And some hospitals in the past had done that. I believe Rutland did that a number of years ago. They came in mid-year and said, we're hot, we want to comply with our budget, we're going to lower our price. If that doesn't happen and a hospital ends up over, We then go to this statute, 9456H, which authorizes the board to order a hospital to take corrective measures to remediate the deviation. So it's not a penalty, it's a correction to make sure that the budget order is complied with. And one of the ways we can do that is by lowering that commercial rate increase. So no, you don't take away the money. You don't say, hey, give me $80 million back. And you don't say, hey, go undo that guy's knee you did. But what you do is you lower the price. And that's what we did. So UVM, I think in fiscal year 25 had about a 3 or 3.4-ish rate increase. So we said you can charge 3.4% more, which was our guidance that year. And then we applied the reduction due to the overage, which divided by 2 years ended up being minus 4.4%. So all told, for fiscal year 25, they had a minus 1% price. So when they go to Blue Cross and they say, hey, we're $100 in 24, we now got our budget order from the board, we're now $99 for that service, right? They had asked for, I think, 8% increase total. So they wanted to go from 100 to 108. We said, no, you can go from 100 to 103.50. And then we said, you have a minus 4.4, so you have to pay 99 because you're too high the year before.
Mhm.
Does that make sense?
Makes sense. Actually, back to something that you said before, just because, and talking about authority, you were talking about it would take an audit, it would take an audit. Do you have the authority to do an audit?
To ask our general counsel.
So the record of the Barber General Counsel, not explicit authority, so if we did have it, we'd have to find implied authority.
And then you'd have to have money to do it.
Mhm.
There will be discussion, I think, there has been about our resources, just to give you a sense. The hospital systems finance team is 3 people. So, and they're really good, but it's not the deepest of benches given the complexity and difficulty of the problem. I have been loath to ask for resources. We have not asked for resources since I've been here. But we can't have our 3 people during a hospital budget process dig into all these paths in 14, 15 hospitals in 2.5 months. So we do the best we can and we make the decisions we do. And maybe that's right. Maybe that's the right way to go, is do that. But if you want to get deeper, you either have to audit, you have to get a contractor, or somebody has to do it.
I think Daisy had a question.
My question is kind of 30,000-foot level, but I'm just really baffled how our system-wide financial challenges can be so severe and, you know, in contrast to the rest or comparison to the rest of the nation. And are our hospitals all meeting certification and accreditation standards like Joint Commission? How are they still meeting those and it not showing up in, or how is it not showing up in their certification when we're in such a financial disaster? Like I would expect some of those performance standards to impact their financial operations too, if that makes sense.
I'm not an expert on how the financial component for hospitals would relate to accreditations. And what I can speak to is that we have seen in the last budget cycle some concerns, not concerns, but some issues on some scales with quality. And we know that at some hospitals from the Oliver Wyman report, the volume by which they were performing services was below appropriate thresholds. So if you want to do a very complex knee procedure, you need to do more than, I'm making up a number, 5 a year, right? If you want to do births safely, there's a certain number. And so some hospitals and some services were below that. So as a hospital, well, if you lose this service that you're not providing frequently enough, that might be a net positive financially and a net positive for patient safety and the system. Medicare has various programs through which they evaluate hospital quality and safety. And there's a lot of complexity to quality. There's a lot of different lenses you can look at it in reports, and there's a lot of nuance there. One of the ones we looked at this year was Medicare STAR reports. It's a general safety grade. It's a blunt evaluation, really. But we did see some deterioration on those STAR ratings for Medicare. And we did see Medicare impose financial penalties and fines on some of our hospitals for quality. And what I think that speaks to is the system-wide problem. They don't necessarily have the resources or the people that they need to ensure that quality and safety is staying exactly where they want. And they all want it as high as they can, right? They don't like this either. And there's many, many, many good quality stories in Vermont hospitals. I'm not suggesting we have a quality problem in the state. I'm suggesting that in some areas we are seeing it not where we had it before. And without additional dollars to invest in it, that gets more challenging. And I think it does speak to the ability to discharge patients. So one of the ones we had problems with was pressure ulcers. Patients are staying in the hospital too long. The length of stay is going too long. You need to treat the patient and address their needs and turn them over and allow them to move so that they don't get pressure ulcers. So if they're in the hospital too long and they shouldn't be there, it hurts quality and it hurts patients. So again, I think that speaks to the system-wide problem.
Let's finish hospital budget enforcement, and then it looks like a great time to take a break.
Great, okay. I think I kind of spoke to this. This is the charge increases, the amount for the service, $100 to $110 I was talking about. This gives you a sense of the last couple of years. This is the charge increase for fiscal year 23. System-wide, we allowed a 10.5% charge increase across all of Vermont hospitals. And you can see how that was allocated amongst various. So yeah, Rutland had 17.4% charge increase. UVM had 10, North Country had 12.2, Copley had 12, CWMC 10. Those are very, very large rate increases. UVM in that year did something a little bit different. It was they had two different metrics. They had a 14.77% commercial effective rate as well, which I don't want to get into the details of that. But in any event, then you go to fiscal year 24, system-wide, there's a request for 10.6%. Given all the issues we've been speaking about, the board approved a 4.1%, right? So they asked for 10, we approved 4. There's consequences to that for hospitals. There's benefits to others in the system. That's the thing we're trying to balance. And you can see the amounts approved at each of the hospitals. So here at Copley, we gave ultimately a 15% with the mid-year. Northwestern 6, North Country 4, Northwestern 6, UVM 3. And then fiscal year 25 is a 5.7% system-wide. We approved 3.4. And then there's the 2 enforcements here at the end that impacted that, what we did in 25. So that's all I have.
On hospital budget decisions. Thank you. Let's take a break. Let's be back here at 11:10.